Hi, Yasmin. I'm so glad you're having me with you for this interview. So, my name is Dr. Oula Khoury. I'm a clinical psychologist. I specialize in treating children and adolescents. I'm an assistant professor, clinical assistant professor at the School of Medicine at Stanford, and the co-director of the inpatient psychiatric unit team at Stanford.
Amazing. Yeah, I actually did look into what you do just to make sure I know what I'm getting myself into and whatnot. Um, and with this website, Katie Development, we kind of like the thing we focus on is the development of kids and the effects on their surroundings and what can help them. Um, so I was thinking with this interview, we could kind of join the two topics we have here, with your focus in what you do and with the focus we have here on this website. Um, and to start, given your clinical focus on mood and anxiety disorders in youth, I was going to ask you, or to start with asking, what are some of the most common challenges you observe in today's youth?
And it's a broad question, I would say. And I'm happy to answer that question from a developmental lens as well. But I would say, depending on that, sort of, I assume you're saying challenges in terms of mental health challenges. Okay.
Yes,
Okay. Because there's many challenges, right? It's like you want
absolutely.
to, yeah. Yeah. And I think it really depends on the developmental level. If we talk about the adolescence years between 13 to 18, which is the group that I see the most, although I have in previous times of my career focused on the younger age. But if we talk about adolescence age, I would say the most common diagnosis or mental health issues that we see is depression and anxiety. Um, and I think nationally, the rates are, we know that um, I want to say 30% of youth experience a diagnosable mental health condition.
Hmm. Yeah. What do you think it like comes from? Why is it such a big issue in today's youth?
So I'm not sure, sort of over the years, whether this has always been an issue and only we've gotten better at identifying it and treating it. I think I'm always looking at mental health presentations from the biopsychosocial model, which is a framework or a lens that looks at multiple reasons for why a mental health disorder may represent or present in a child or an adult. The one factor is the bio, which is biological components that are often related to your genetic predisposition, which we know in depression and anxiety, there are some contributions to genetics as well. And those, again, the biological factors that contribute to the development of the mental health condition. The other aspect is what we call psycho, which talks about the psychological aspect of what help or contributes to the development and maintenance of a disorder. Psychological aspects are often, looked at as your patterns of thoughts, behaviors, and feelings. We like in CBT, we like to look at it as the triangle, which is like cognitions, behaviors, and emotions, which are impact each other. But we know that in youth and young children who are vulnerable to developing mood or anxiety disorders, we see a pattern of thoughts that are cognitive traps or thinking mistakes that make you more likely to focus on negative events within your day or generalize a single event that may be sort of objectively adverse into this is going to be this way forever, this is going to impact all of my life. I like to sometimes um, give the example of, the most prominent example is often that I see in the Bay Area are youth or even tweens who are getting a B or a C on an exam and they're spiraling in their anxious thoughts and saying, I'm never going to get into any college now. I am not going to be able to get a job and I'm going to be homeless living in a box under a bridge. And this is all sort of as a result of this one C. And those feelings and thoughts feel very real to the individual who's experiencing a mood or anxiety disorder and further contribute to that vicious cycle of reinforcing those feelings, right? And the third aspect, I said, biopsychosocial model. We talked about the bio, we talked about the psychological. The third aspect is social, where oftentimes we know from a lot of research that youth who are experiencing a sense of isolation, youth who are experiencing conflict or chronic invalidation at home, poor family cohesion, youth who are experiencing bullying at school or online, or just difficulties connecting with others who are their age, may experience more loneliness, isolation, and as a result, also experience higher rates of depression.
Hmm. Yeah, that makes sense. Um, is there like anything that could be done to aid children in these like times? Like maybe from like a parenting aspect, is there a way that a parent could help a child with these struggles to make it seem less, overwhelming?
Yeah, absolutely. Absolutely. I think that a big portion of my work is with parents, especially during the adolescence here and the young age, when you're sort of school age children. Parents, I'm always saying, while you may not have contributed necessarily into the development of this mood disorder of your child, it's not your fault, but it is your responsibility to figure out how to support your child in navigating those very difficult challenges. And I would say the biggest, most important thing parents can do is seek help when they're noticing warning signs in regards to depression or anxiety that's impacting um, the day-to-day functioning or ability to do things for their child is seeking help. And there are two types of help that parents can seek, or well, there are many, but two sort of types is the therapeutic aspect therapy, which is usually the first line. And there's also psychiatric or medication management support that they can seek in order to alleviate or address that biological component related to depression and anxiety. I think that's probably one of the single most important things parents can do. The second part, I would say, just being involved and aware of what your child's like of your child's life, what's going on, noticing some warning signs, especially around um, depression or changes in functioning related to depression in order to have conversations and open conversations with your child about what's going on that's coming from a place of concern versus a place of judgment or anger. Some of the most prominent, I would say, warning signs we want parents to be aware of is any significant changes in sleeping patterns, such as not sleeping at all or oversleeping. Any significant changes in appetite, such as eating too much and gaining excessive weight, or not eating at all, not having an appetite and losing some weight. Changes in mood, such as, my child or my teen looks grumpy, sad, doesn't have any energy, prefers to stay in their room, in their bedroom, pretty isolating pretty much from others, including friends. And if your child or teen suddenly loses interest in things that they've previously really enjoyed doing. So if your child was playing soccer for a while or doing art, and suddenly they no longer are interested in that activity despite being very engaged in it. That's another thing to pay attention to. Oftentimes with kids who are experiencing some significant clinically significant depression symptoms, we also sometimes see a decline in their grades. Children who or youth who used to be straight A students suddenly are, that we see significant decline in their grades, and that's due to difficulties in motivation, continuing to feel motivated to work and persist in their effort around school. Depression sometimes often, well, actually, oftentimes impacts your attention span, and your ability to um, sleep well, which also eventually can impact your attention span. So there are some big warning signs that parents can observe and notice. I would say the third advice that I would have to parents is how do we approach that conversation with our child in a way that feels um, one, manageable for your child. We know that teenagers, from a developmental standpoint, it's a time of separation and individuation. It's a time where a lot of teens may tell their friends first about how they're feeling and experiencing, any mental health concerns they're experiencing before they're telling their parents. So, how to approach this with gentleness, with sensitivity, and most importantly, um, withholding any judgment, positive or negative, that I may have as I'm approaching that topic, right? And
Mhm.
oftentimes, I recommend starting with, just stating the fact, finding a time where you're uninterrupted, you can sit down and have a conversation with your child where you're remaining calm and well regulated yourself, not demonstrating a lot of panic or anxiety or stress or anger. And you're able to ask, just state the fact. I've noticed lately that you haven't been going out with your friends as usual, or you've lost interest in some of the things you used to enjoy, like soccer or whatever activity you are doing. And I'm worried about you. I really want to check in and see if everything is okay. And I want you to know that, like, if you're struggling with anything, I'm here to help you. So
Mhm.
really making it a very intentional statement where you're, communicating to your child what you've observed. You're also communicating that you're concerned and you're communicating your intention. My intention is to be there for you, to support you and help you. How can I help?
Right. Do you think how a parent presents themselves will affect like how that conversation goes? Because you mentioned not to be panicked, but like I've observed from many adults that I know, it's kind of hard to separate yourself from the situation.
Yeah, yeah. And as a mom of three boys myself, three teenage boys, I totally get it. When your child is in pain, our instinct as parents, one is it really hits hard, right? It is very dysregulating because we're worried, we care about our children, we want to help our children, and knowing that or noticing that my child is struggling with their mental health may actually indeed affect me tremendously, right? So why is it important how we approach our child, our demeanor? It's important because I believe that when we're presenting in a sort of there's various emotions that you can present with when you're talking to your child. You can be anxious and nervous and worried. You can be angry and dysregulated and disappointed over maybe failed grades or changes in grades. Um, and I think, a lot of kids and teens and even young children are very good at detecting and identifying those emotions in their parents. And when I am seeing my parent being dysregulated, one of two things is going to usually happen. One, it's not going to help me remain regulated. It's going to make me feel more dysregulated. It's likely to cause the child to be more reserved in what they share, withhold information, whether it's because I'm worried about my parents' reaction, or whether it's because I don't want to burden my parent with my problems because they already seem like they're struggling with their own. They have enough on their plate, right? So this is one of the most common advice I give with, especially in the context of suicidality and depression, is a lot of teens tell me on a daily basis is that one of the things that holds them back from disclosing thoughts about suicide or severe struggles with depression and anxiety with their parents is, one, I don't want to burden my parents. They already have a lot on their plates. And two, I don't think they'll understand. They may have a big reaction that overwhelms me as well. And, in some Other cases, they may be worried about parents judging them or making statements that are unhelpful or invalidating, such as most common one, what do you have to be depressed about? You know,
Hmm.
you know, let's take a look at the children in Africa who don't have food or shelter. You have everything going on. I don't understand. Your life is great.
Yeah.
Kind of statement may really make it a lot harder for the child to disclose symptoms of depression or anxiety or struggles that they're having.
Yeah.
While we're on the topic of how parents can affect their children, I wanted to ask you about parenting styles, what you think could be the most detrimental or could be the most helpful for a child, and in general, how different ways parents interact with their children, how it affects them.
So from a parenting style, we know that there are generally sort of in literature we speak of like we talk about four different parenting style: authoritative, authoritarian, permissive, and neglectful. And sort of authoritative parenting style is viewed as the ideal um, parenting style, at least in Western cultures, where there is a balance between high demands or expectations, but also high levels of support to help the child meet those demands and expectations. And generally speaking, authoritative parenting style is associated with, better outcomes academically, emotional, social development, and well-being, and definitely more positive relationship with parents. Authoritarian parenting style is often sort of characterized by very high demands and expectations. Oftentimes, this as the name would suggest, authoritarian, sort of top-down approach to the child needs to do what the parent is saying, but also very little or a lot more limited support to the child to meet those high expectations. So authoritarian is high demand, but low support or lower support. Permissive parenting is characterized by low demand and low support. And these are parents who oftentimes have very limited rules or expectations at home. And also, um, they're really like not very much, I mean, actually, they may support, I apologize. I think that it's low demands, high support, which is I give you a lot of support, but also like there are no expectations or rules. And then neglectful parenting is when there's no demands and also no supports, right? I think
Mm.
what the research tells us is that the neglectful parenting is probably one of the most unhelpful or is associated with the most negative consequences for children. Permissive parenting as well. I would say from that perspective, there may be adverse outcome. There was a lot of study that looked at authoritarian and authoritative parenting. Obviously, authoritative parenting where you're having some kind of expectations, you're not removing all of the demands and expectations of your child. And I'll give a specific example in the case of mood disorders as well. But you're also offering a lot of support to your child is associated with best outcome. Um, in terms of authoritarian parenting, there's been some studies that looked at that parenting style in across different cultures. And the reason why I hesitate, because generally it's associated with negative outcomes. However, especially around like self-esteem and sort of academic achievement, but also depending on the cultural context in which parenting occurs, if this is consistent with cultural expectations, especially for father's parenting style, it might not have as much of an adverse effect as it
Mhm.
does in Western culture because of, again, cultural expectations around parenting. But let me give an example of how this plays out in the context of mood and anxiety issues. So, oftentimes, one of the challenges that let's stick with a mood depression, a teenager who may be depressed, and as a result, they're having very low energy. They're struggling with sleeping at night, which is making it very difficult to wake up in the morning for school. They are having a hard time focusing and having motivation to complete their homework. And as a result, they're not completing homework and schoolwork, and their grades are dropping. It is, so let's say we've done the psychoeducation with parents and they understand that all of these changes, their room is a mess, all of the stuff that we said, all right? And let's say we've done some education with the parents and now they understand that the reason why your child is not completing all those tasks is because they have depression.
Mhm.
Um, Now, I see, this can go two ways. You see parents who are like, okay, we're going to take off all demands. We're not going to ask them to do anything. We're going to let them sleep all day. We're not going to push them to go to school or complete any homework because, they're depressed. We got to wait until their depression gets better before we can ask or demand anything of them.
Mhm.
So that's more of a really very permissive response, right? I'm going to take off all demands and I'm going to let you take your time, which I do not recommend ever. Actually, I do not recommend that we take off everything off the child's plate because we know that in the process of treating depression, behavioral activation, which is gradually engaging in activating tasks, whether they're goal-oriented task or pleasurable activity, is part of that recovery. And if I'm allowing my kid to just lay in bed all day, that's going to be a vicious cycle to really dig you deeper into depression. So I don't want that.
Mhm.
I also don't want the parents to say, oh, these are the expectations. You have to do 2 hours of homework, 3 hours of, 1 hour of chores every day. And I'm very sort of like approaching it in a rigid way of, I don't care that you're depressed and that you don't have energy, like suck it up and get up and do it. That's not helpful at all. And that's more of an authoritarian stance towards that. Is like the expectations I'm gonna hold firm on those expectations and I'm not gonna give you support. Oftentimes, the more reasonable approach to that would be I'm going to modify my expectations of you and be more flexible around them, recognizing that depression is an illness that affects your energy level, your motivation, all of those aspects of functioning. But at the same time, I'm going to continue to scaffold and sort of create those intermediate goals to get you back to that level of functioning slowly with support. How can I support you in getting up in the morning to school? Recognizing that removing all of those expectations and just letting my child, and there's a kid who said, bed rot. Just letting my child bed rot is going to be actually adversely impacting their depression. And it's a fine balance between sort of holding firm on some things and supporting your child in meeting those goals, especially during those hard times.
Yeah. So is it the focus to kind of keep them in keeping them moving, is it important to keep like the routine up, or is it just based on just having them do something? Like, is there a difference in the two?
Yeah, absolutely. So there's a term we love to talk about in psychology. It's called behavioral activation, especially in the context of depression. That's really very effective on its own as an intervention, even without a full course of treatment for depression in adolescents and in adults. And behavioral activation speaks to the really ways to, well, I guess it's an intervention that is designed to break the vicious cycle of depression, so of depression feedback. And here's what I
Mhm.
mean. So I'm depressed. Let's say I'm depressed right now, and then I am don't have energy. I stay in my bed. I isolate in my room. I don't want to go to work or school. My friends are texting me, and I'm not texting them back. I'm not engaging with them. And as a result, what's happening is I'm staying in bed and I'm ruminating over very negative thoughts that I'm having in my head. And I'm feeling pretty lonely because my friends are going to text me a few, maybe weeks, but then they're going to give up if I'm not responding or engaging with them, right? So sort of this sense of loneliness, lack of purpose. Maybe I'm not feeling great about myself because I don't have the energy to get up in the morning, shower, take care of my hygiene. So now I'm also feeling negatively about myself. It's gonna dig me deeper into a state of depression. What we know is to break that cycle is behavioral activation can be very effective, which is sort of the term of like fake it until you make it type of situation, meaning that I'm going to develop a list of activities, and I usually help my patient develop two kinds of list of activities. One is a productive, value consistent, productive list of activities that you need to do, and the other one is a more pleasure-based list of activities. What is something that you enjoy doing? And sometimes kids with severe depression will tell me, I don't enjoy anything anymore. And I say, what is something that you used to enjoy doing? And then versus what is something that you need to get done. With adults, we talk about paying your bills as a very critical aspect if you're feeling very depressed, right? But with kids, it's like, can we get one homework assignment done? Maybe you can't get five today, but you're getting one. And then we schedule them in a realistic way, taking into consideration the severity of their depression in order to help them um, gradually sort of increase their activation level, their activity levels. And the key here is I want you engaging in something that moves you, gets you out of bed. A lot of kids tell me, oh, I want to watch TikTok. That's my behavioral activation. I was like, great, watch TikTok for like whatever, half an hour. But I need you also to, it could be a task as simple as by 10 a.m. every day, I'm going to be able to get up, brush my teeth, and take a shower. Because that
Mhm.
sometimes is very challenging when you have severe depression. Or it could be something as simple as I'm going to take my dog for a walk every day for 10 minutes. And
Mhm.
that's my behavioral activation because it's moving in my body. And again, you start small, you start gradual. The idea is that you put modest goals that you can do them consistently. So if someone tells me my behavioral activation plan is that I'm going for an hour and a half to the gym every day and weightlifting when they've never been to the gym before, I'm like, that's not realistic and you're not going to keep it up. How about we start with maybe 50 minutes of a walk and maintain that consistently, and then we can build on that. Does that make sense? Yeah, and that's
Yes.
we know that this intervention on its own can contribute to significant improvements in mood, even in the absence of any other sort of intervention.
Hmm. So like the consistency is important, but it's more on like the small things to get them
Exactly.
out, yeah, out of the bed rotting.
Exactly.
Yeah, okay. Um,
While we're on the topic of suicide, I just wanted to talk a little bit about one of your, sorry about my dog in the back, one of your clinical focuses, which is on, if I'm right, culture and its impact on teens and suicidality. Can you talk a little bit about that?
I'll start with that. Yeah, absolutely. So I've spent probably the last 7, 8, 9 years really like focused on the as part of my specialty, both in my research as well as my clinical practice, is like obviously the interest in this, the expertise is in the, I guess the area of adolescent suicide, but more specifically, I am extremely interested and curious about what are some cultural factors impacting the risk of suicide for adolescents, both on the, family cultural factors as well as individual experiences related to their culture and ethnicity. When I talk about culture, oftentimes I think about, minoritized ethnic identities or cultural identities in the US, as well as gender and sexual minority kids. Sort of, I look at culture from a broad spectrum. And, there's a few interesting statistics I like to usually pull to talk about sort of why is it important to talk about culture in the context of suicidality is one, we know there's a wide diversity in the rates of suicide or experiences of suicidal behaviors and thoughts across different ethnic groups and across different sort of gender identities and sexual identities. And I'll start with the gender and sexual identities, as we know that youth who identify as transgender, gender non-binary, gender expansive or questioning, youth who identify as gay, lesbian, bisexual, or questioning within their sexual orientation are at a significantly higher risk of both suicide, experiencing suicidal ideation, and having had suicide attempt previously. And when I started in my career path, I never intended on becoming or having expertise within the gender and sexual minority youth, but it was really inevitable when the majority of children, I would say more than 50% of children I work with on the inpatient psychiatric unit who are experiencing acute suicidal stress identify as some sort of a gender or sexual minority um, like identify as having an identity of gender and sexual minority of some sort, oftentimes having also intersecting identities, meaning, I'm going to give a specific example. I may have both identify as a gender or sexual minority and have an ethnic minority identity. So we talk
Mhm.
about intersecting identities that are sometimes a double whammy and complicate sort of those experiences and it could increase the risk. So I think that it's really important, one, to look at this because of those big discrepancies in rates that we know exist in epidemiological studies and in the CDC data annually, where we see those higher risk. The second reason why this is really relevant is because I think in the sort of literature where we look at like how do we assess for suicide risk, early identification of suicide risk, and prevention efforts to save lives. Those are life-saving interventions. We rarely see considerations for what works for those minority kids or youth. We rarely see empirically supported structures, ways even to ask about those minority unique experiences that may exacerbate your risk of mental health concerns or suicide. So I feel personally like this is a very important piece, a gap in the literature currently around suicide risk management, identification, and intervention, prevention that we have to address from a stance of like equity, that our treatment and intervention recommendations have to be equitable and appropriate for all kinds of teens or the population that we serve, right? So then you're asking, what are some of those culturally salient risk and protective factors that we see? And I think what we know, and this is taking from a study that we did that looked at in-depth factors that may sort of we did a thorough literature review of what's out there in terms of like the risk and protective factors. We also did in-depth clinical interviews with kids, but generally speaking, there's a term we call minority stress, which is refers to the experiences of difficulties, hardship, daily challenges, sometimes discrimination or oppression as it relates or pertains to your minority identity, whether it's your gender or ethnic identity. A child who or a teen who is identifying as, let's say, male trans or female trans, a youth who is being bullied at school, rejected, cannot find maybe a summer job because of discrimination against their identity. Those are experiences of minority stress that we know those youth experiences on a daily basis. And they're not accounted to. Those are added to the normal stressors that everybody experiences. So that's one factor that increases the risk of your adverse mental health concerns and suicidality among youth who are identifying as minority or cultural minority. Other factors have to do with um, um, family discord versus cohesion, because especially in collectivistic cultures, such as Asian American youth, Asian American cultures, Middle Eastern cultures, family cohesion is a really important aspect and a priority. And when there is conflict in the family, sometimes with maybe parents are first generation immigrant, wanna parent and do things the way they did it in their original country, and the child is growing up in a American culture, is rebelling, rejecting the primary sort of culture of the parents, and that's causing more conflict, whether it's because parents are experiencing hardship and they're having to work multiple jobs in order to support their families in the new country that they've immigrated to. There's various reasons, but higher rates of family conflict and lower family cohesion increases the risk of suicide among everybody, but those are more salient for cultural minority youth. And I think parents' rejection around your gender or sexuality is a well-known, well-documented big risk factor for suicide for gay, lesbian, transgender youth.
Yeah.
And can make a huge difference being accepted by your core family and friends versus being rejected by your family and friends.
Mhm. Well, on this topic of, intersectionality and whatnot that maybe parents don't understand, is there a way to kind of help parents connect with something that they might not directly relate to? Like whether it's an ethical or sorry, not ethical, ethnic or, you know, sexuality based topic. Is there a way to help, like, get them to understand what their child might be going through?
Um, yes, there are. They're not. Look, the answer is never really simple, but I think, you can think of there are many cultures. I personally am Middle Eastern, and within the Middle Eastern culture, there are very strong opinions or perceptions around sexual minority youth and sexuality, gender, right? Um, and then you have families who come with even stronger opinions because of those cultural views, sometimes religious worldviews around the lack of acceptability of gender or sexuality, specific gender and sexual identities in their child. Um, I think the answer is not easy. I think that when we're approaching it, one of the biggest mistakes that I see clinicians do is quickly dismissing parents as supportive, and excluding them from treatment to protect the child.
Mhm.
I believe that it's just as important, more even important, to work with parents who are struggling with accepting their gender and sexual, like their child's gender and sexual identity, in order to help them navigate that. And I believe it's important to do so without judgment on our end as clinicians, which can be very difficult. I've
Mhm.
definitely had parents who've told me, I'd rather have a dead child than have a gay child. And that was very religiously driven. And it's a very difficult things to hear. And I think that unless clinicians are willing to sit with those parents and recognize their own pain, because in their worldview, this is an unacceptable thing, something that can be associated with shame, it can be associated with a lot of things. And we have to understand that this is a journey for parents to accept or be okay with that identity, that it's going to take time. And, some families, and so with some parents, it's quick. Yes, I accept you. I'm going to support you with whatever. And that's great when that happens. But a lot of time, that's not how things happen. And having that tolerance to work through the process and look at there's a process also of being willing to as a one dad once told me, I need to grieve that I no longer have a daughter. I need
Mhm.
to come to terms with that. It's a process. This is difficult for me. I woke up one day, I had a my little daughter that I loved and cared about, and suddenly she told me now she's a boy, and I'm not ready to lose my daughter. There's a process
Mhm.
of grief and change, um and it's a very challenging one. So I think someone needs to be willing to do that work with parents to help them get to a place where they can accept the teenagers. But it's not something that should be put on the teen themselves to do.
Yeah. Is there some stuff that a parent could do themselves to maybe, um, like I know with some parents they might be a little bit more set in their ways because it's a very deep rooted idea or something that's not so easy to just to get past. But if a parent is willing and is trying, let's say,
Huh.
there's stuff that they can do to without maybe just the child involved, just to help them understand a viewpoint that might not be so similar to their own.
Yes, I absolutely think there's a lot that can be done. And I oftentimes um, reference the studies and research that's been done with the gender and gender and the sexual minority youth, where an accepting family makes a big difference in reducing the risk of suicide, improving mental health outcomes. I encourage parents a lot of time to proactively seek information, but from reputable sources, from places that are presenting data and facts versus, anecdotal stories that are not often sort of based in reality, that they look at that data and they seek out opposite opinions of themselves so they can really check and challenge some of those thoughts that they hold very strongly and sort of just consider, right? I also urge them to listen to their children with an open mind, without judgment, and understand their children's experiences, which I think can be very helpful. One very um, close to my heart organization that I absolutely love, that I think offers a lot of good psychoeducation online, is the Trevor Project,
Mm-hmm.
often asking both teens and parents to go there, look through it. They have not only, it's an organization that's dedicating to supporting LGBTQ plus youth in their journeys and navigating mental health and also safety in the context of suicide, but they have a tremendous amount of psychoeducation that's easily accessible on their website, both for parents, allies, and kids.
Mm. Yeah.
All right, don't want to keep you here for too long. So,
Thank you for having this interview with me. I definitely learned a lot. So I really appreciate it.
Thank you, Yasmin. It's been a pleasure talking to you.
Yeah.
Bye.